Welcome everyone to this session of ISCRR's Learning Series. My name's Janine McMillan. I'm one of the acting co-directors of ISCRR and also the research lead. Firstly, I'd like to acknowledge the traditional owners of the lands on which we work and live, the Wadawurrung people, the Woiwurrung and the Boonwurrung peoples of the Kulin Nation, and pay our respects to their elders, past, present and emerging. And I'd like to extend this acknowledgement to the traditional owners of the lands in which you work and live. So please feel free to make an acknowledgement in the chat. ISCRR is a unique partnership between Monash University and WorkSafe Victoria. Over the past 15 years, we've had the pleasure of working with world-leading researchers around the globe in the field of workplace health and safety. So we are proud to be hosting today's session titled Opioid Use Trends Among Australian Injured Workers After Codeine Schedule Changes. And this will be presented by Dr. Michael Di Donato. Michael is a postdoctoral research fellow in the Healthy Working Lives Research Group of the School of Public Health and Preventive Medicine, Monash University. He is a health services researcher and utilises quantitative and comparative policy methods in his work. His PhD studies explored the interaction between income support systems and healthcare for workers with low back pain. Michael extended this work in his postdoctoral research, conducting analyses of health service use by workers with low back pain for the Australia and New Zealand Low Back Pain Research Network Centre for Research Excellence, and social security and health service use by injured workers with long-term claims for a project funded by the New South Wales State Insurance Regulatory Authority. So just a little bit of housekeeping first. This session will be recorded and will be available to view on ISCRR's channels in the future. There is an opportunity to post questions in the Q&A and there'll also be a question and answer time at the end. So now I'll hand over to Michael. Thank you, Michael, for joining us and for presenting this today.
Fantastic. Thank you, Janine, for that very kind introduction. Let me just share my screen. We can get underway. I will just note my neighbour has chosen this moment to deploy his leaf blower. So hopefully the background noise is a minimum, but we'll see how we go today. But like I said, thank you for having me here today to talk about opioid use trends in injured Australian workers following codeine schedule changes back in 2018. A few acknowledgements before I get underway. My co-authors on this paper should note as well the paper will be available later this year, hopefully published later this year rather. But my co-authors Stephanie Matheson, Giovanni Ferreira, Ting Jia, Jonas Tefera, Christina Abdel-Shahid, Chris Ma and Alex Colley. And I'd like to thank WorkSafe Victoria who supplied the data for use in this study. But the views expressed in my presentation today are those of myself and my co-authors and not necessarily the views of WorkSafe Victoria. And also a big thank you to the funding for this, which was, as Janine mentioned, the Australia and New Zealand Low Back Pain Research Network, which is a National Health and Medical Research Council Centre of Research Excellence. So, opioids and opioids for musculoskeletal conditions in particular. Recommendations for the use of opioids have changed in recent years with greater recognition that the risks may outweigh the potential benefits. For some common conditions, such as low back pain, there's really limited evidence that opioids provide clinically important benefits to pain or disability. And in some cases can, in some American studies we're aware of, it can actually extend disability. There's a number of known side effects, including overdose or risk of overdose rather, dizziness, sedation, depression, and long-term use may be associated with addiction, analgesic intolerance. That's where the opioids become less effective over time, and increased use of risk of illicit drugs. There's some fantastic recent literature that's come out, notably the OPAL trial was published in The Lancet last year. I recommend reading it if you can. It was a triple-blinded, placebo-controlled, randomized controlled trial. So a lot of jargon there, but basically just to say that that's kind of the highest quality scientific trial that can be conducted, and it was conducted in New South Wales, and it found no significant difference in pain severity with people given opioids versus a placebo for low back pain and neck pain. So some really interesting results there. I recommend you have a read if you can. So the risks of overuse and overdose for opioids have become pertinent issues for policymakers globally. And it's meant that they've tried to deploy a number of methods to reduce the risk of the harms of opioids. In Australia, this has meant really a couple of things. One has been the introduction of prescription drug monitoring programs. In Victoria, that's called SafeScript. The name of the one in South Australia is on the tip of my tongue, but I can't remember. But those are effectively information technology networks to make sure that doctors are not over-prescribing opioids, so that they can be aware if somebody's gone to another doctor and been prescribed opioids or a number of other harmful medicines. It's not just opioids that PDMPs are used for. And the other method is some access restrictions or restrictions to certain doses of opioids. So in 2015, there was a proposal to increase the schedule of codeine due to its potential harms and potential risk of overdose, because at the time you could purchase low-dose codeine-containing products from pharmacies without a prescription from a medical doctor. So I should just explain what schedules are briefly, because they're not a term we hear regularly. So in Australia, chemicals and poisons are all scheduled, 1 through 9 schedules there are. The important ones for humans for therapeutic use are Schedule 2, 3, 4, and 8. Schedule 2 is pharmacy medicines, so you don't need a prescription to get them, and you can get them from a pharmacy, but you don't have to. So that's things like paracetamol, which we know we can get from a supermarket. Schedule 3 is pharmacist-only medicines, and that's what codeine was until 2018, when it changed. Now, this is medicines you don't need a prescription, but you must get them from a pharmacy. So that's things like pseudoephedrine, which you might get if you've got a cold or flu. Schedule 4, you need to get from a pharmacy and have a prescription, and that's the current state of all codeine-containing products. And Schedule 8 are controlled drugs, which you need a prescription and from a pharmacy and have more controls around them about how you can get them. And that's things like oxycodone or tramadol, for example. But the real gist of it was that codeine was up-scheduled. So that meant it moved from Schedule 3 to Schedule 4. So you previously could get products with 15 milligrams of codeine in them, probably combined with paracetamol from a pharmacy without a prescription. And after February 2018, you needed a prescription for those. So what happened there? Well, there's a number of studies that have already looked at the outcomes of upscheduling in Australia, such as other opioid supply, overdoses, opioid use disorders, emergency department presentations, but not specifically in workers. And we know that injured workers is a large sample of people. Musculoskeletal conditions and injuries in workers' compensation was about half of time loss claims in 21-22 financial year, which is about 64,000 claims. So it's a substantial number of people. And these workers' compensation schemes are paying for the costs of reasonable and necessary healthcare, which includes medicines such as codeine and other opioids. So in this study, we sought to do 2 things. Firstly, describe the prevalence and pattern of opioid and pain medicine dispensing over time, so all pain medicines, and describe the association between upscheduling of low-dose codeine and the number and rate of opioids and pain medicines dispensed, and the dose of opioids as well. And this is in injured workers with workers' compensation claims for musculoskeletal conditions. So the data and what our sample, we used a sample of claims from Victoria, time loss workers' compensation claims for musculoskeletal conditions between the 1st of February 2010 and the 31st of January 2019. So that's, as you can imagine, it's quite a while before upscheduling and then about a year afterwards. At this time, Victoria had a labour force of about 3.2 million workers. We included only people who had exceeded the employer excess period. So this is technically a slightly more severe group of claims. That's people who've already been off work for 10 business days, I should say. Musculoskeletal conditions included in our sample include things like muscle and tendon diseases, trauma to joints and ligaments, spinal vertebrae and intervertebral disc diseases, so low back pain, but not fractures. So we didn't include major trauma like fractures, limb fractures, etc. We included medicines for these workers that were funded by workers' compensation in the first year since the insurer received their claim, so the first year of their claim, effectively. And so these are the major categories of medicines that you're going to see today, and I've color-coded them so that we can they're consistent throughout. But there's 4 categories of medicines that we looked at. So upscheduled low-dose codeine, that's really the medicine of interest. That's where the policy change occurred. And that's medicines where each tablet, if you will, has less than or equal to 15 milligrams of codeine in it. So typically that might be codeine, 12.8 milligrams, and some ibuprofen, a combination. There's high dose codeine, and that's any codeine containing product with more than 15 milligrams of codeine. So that's codeine 30 milligrams plus 500 milligrams of paracetamol. Opioids excluding codeine, so this is the other opioids, and that's any strength. So that could be oxycodone 5 milligrams, tramadol 50 milligrams, and other pain medicines. So this is a kind of a larger category. Other pain medicines are medicines that you would use for painful conditions, for painful musculoskeletal conditions. So that could include paracetamol, but also pregabalin, which is a gabapentinoid, and diazepam as well. So 4 main categories there: low-dose codeine, high-dose codeine, opioids, and then other pain medicines. That's what we'll talk about today. So let's get to the results. Who was dispensed pain medicines and opioids? So our sample included 80,324 workers across that quite long time series. Along the y-axis there, you just have the number of workers. You can see it goes up to 80,000. On the left here, with the green and the grey, we have other pain medicines and all opioids. And you can see that about just under a third of this sample were ever dispensed opioids during their first year of their claim, and 25.9% dispensed other pain medicines. Now, when I say dispensed, what I'm referring to is they went to a pharmacy and they were dispensed a packet of medicines or a number of medicines. It's not referring to the precise single tablets, it's a dispense. So it's effectively an interaction with a pharmacist for each medicine. On the right here, you can see opioids, so the specific opioids. Those mathematical in the audience will notice that the opioids does not add up equally to all opioids. That's because some people may have had multiple of each of these types of opioids. But what you can see here, importantly, was that opioids excluding codeine was really the major category, with 22.6% of workers ever being dispensed opioids. And in fact, low-dose codeine, only 3% of workers were ever dispensed low-dose codeine. And that's funded by the workers' compensation system. We'll get to why that's important later on. So did upscheduling change the prevalence? Did it change the number of workers who were ever dispensed these medicines? So this figure here, I'll just run you through. If you just imagine these dots are workers when they're starting their claim, and then the line after it is the 1-year follow-up. So you can see that some workers' follow-up may have gotten quite close to upscheduling, but some workers may have been way before. Let's say they had their claim in 2010 and their 1-year follow-up was finished by 2011, in our sample at least. So we grouped workers into 2 groups by whether their claim commenced before or after the upscheduling of low-dose codeine. So that's workers whose claim was prior to February 2018 or after February 2018. Then what we've done is take the number and percentage of workers dispensed each pain medicine and performed as also a statistical analysis, which I'll show you in a moment. But that analysis was fairly comprehensive, and we've adjusted for worker sex, age, employment type, so full-time versus part-time, employer size, nature of injury, bodily location of injury, socioeconomic status, and remoteness as well. So did upscheduling change the prevalence? Well, you can see here the before and after upscheduling of all pain medicines and then opioids on the right there. That should actually be rather. The y-axis here is the percentage of workers. You can see it only goes up to 50%. That's just so it's a bit easier to visualize. But you can see that if we know the grey there was all opioids, prior to upscheduling, 28% of workers had ever been dispensed opioids, but that jumped up to 30% post 2018. And in fact, you can also see in the red here that only 3% of workers were dispensed upscheduled codeine, and it actually dropped to 2.5% of workers post 2018. But also, so did high-dose codeine, we found quite interesting, whereas opioids in the blue there actually went from 22% of workers to 26.7% of workers. So a few interesting little changes there. One thing you can see is there was a minor change of 1% in the other pain medicines. But let's move on to the statistical analysis. I'll just orient you to this graph. This is our logistic regression. On the y-axis here, we have the various categories of pain medicines. It's familiar, you would have seen. Along the bottom there, we have displayed the odds ratio, so the likelihood of ever being dispensed each of those medicines. The reference group here is people whose claims started before upscheduling, and so these odds ratios, where it's less or more likely, are people whose claims started after upscheduling. So with that in mind, workers whose claims started after upscheduling, so post-Feb 2018, were more likely to be dispensed opioids or other pain medicines. So you can see it's to the right of that vertical line, and less likely to be dispensed high-dose codeine. But there was no statistical difference in low-dose codeine. Now, we'll get into this later, but that's probably because the percentage was so low. So we're talking a maximum of only 3% of people ever dispensed low-dose codeine. But we did find it quite interesting that the likelihood of having high-dose codeine was actually less. So yeah, quite interesting findings there, particularly as you can see the opioids excluding codeine tended to jump up quite a bit in the analysis. So what pain medicines were dispensed? Well, these are these same categories of pain medicines that you've seen before. Along the bottom here is the dispense month. So that's when the person has, the worker has gone to the pharmacist and been dispensed these medicines. On the y-axis there, we have the percentage of pain medicines dispensed. So all these pain medicines, what was the percentage? And the first thing you can immediately see is that very low percentage of upscheduled low-dose codeine along the top. You can also see the progressive reduction, I suppose, in high-dose codeine as a percentage of all pain medicines dispensed. But the long and the short of it is that really opioids, whether they're high-dose codeine, low-dose codeine, or other opioids, consist of about 50% of all pain medicines dispensed to injured workers with musculoskeletal conditions. So quite interesting we were able to produce that, but that's the entire series there. What about what opioids were dispensed? So what we've got here is the most frequently dispensed opioids, because there were some main common ones. For those clinically oriented in the audience, I do have the anatomic therapeutic chemical codes there, but otherwise it's just the description of the medicine. And along the y-axis here, we have the percentage of all opioids dispensed. So you can see some really interesting things. Oxycodone and codeine and paracetamol, very popular, probably the most frequent of the medicines, and the dose varies in the paper once it's eventually published. There is a more detailed version of this graph that has the dosage, so whether that was 5 milligram oxycodone or 10 milligram, for example. You can also see the introduction of certain medicines here. So tapentadol, you can see, has become more and more popular. Tapentadol falls into our opioids excluding codeine category. And tapentadol, the advantage of that, I suppose, clinically, is that it's better tolerated by patients, it's meant to have fewer side effects. So you can see that become more popular over time. So we get to the real gist of the analysis here. What was the impact of upscheduling? So we conducted what's called an interrupted time series that measured 3 outcomes: the monthly number of dispensers, the monthly rate of dispensers, so number of dispensers per 1,000 of all pain medicine dispensers, and finally the mean morphine milligram equivalent dose of dispensers. So with opioids, They can all be factored so that they can be compared better. Different types of opioids have a morphine multiplier. So if morphine, which is an opioid, is considered 1, codeine is considered 0.13. So it's a much weaker opioid. The same thing goes the other way for oxycodone. That's equivalent of 1.5 of morphine. So we can compare these doses better. That's essentially what that is. So if you see mean morphine milligram equivalent, that's what that's referring to. But interrupted time series is not something that people see that often. So I'll just orient you to this example. Here we've got the years 2016 through 2019. These are just random data points, and there's no label for that y-axis there. But if you can see what's happening here is we've got a trend that appears to be going up. And then we have this dotted line here, which is the interruption. For us, that's the upscheduling of codeine. And then we have a couple of different lines here. So this dotted line here, the counterfactual, is the trend if nothing had have happened. So if there was no upscheduling, this is what we would expect to have happened. Then we have our dots down here, which is what actually happened, and the trend line for those dots. And we have a step here, which is where there's a sudden drop due to the change. There's a lot to that. The only terms that you need to really know are a step change or a trend change. A step change is a drop or an increase. Trend change is the change in the kind of angle of the line. That's all we need to know for today's purposes. Now, for the interrupted time series, here's our figure again. We're only using a certain portion of the data. So we used 2 years prior to February 2018 to 1 year after February 2018. The reason for this is that you don't want to go too far back in your interrupted time series because other events are occurring at the same time, which we may not be aware of or we may not be able to adjust for. So, for example, the introduction of tebentadol, introduction of other pain medicines that may have occurred. So we've gone for 2 years prior to 1 year after. So let's have a look. There's a lot of graphs here. We'll run through them. This is first the number of dispensers. So the monthly number of dispensers is here on the y-axis. And what you can see is the various different medicines. So we've got low dose codeine, high dose codeine, opioids, excluding codeine, and other pain medicines. Then down here along the bottom, we have the step and the trend change. And for ease of use, these have been expressed as a percentage change. But these are all statistically modeled. They're just expressed as a percentage change. So if we look at low dose codeine here, what we can see is no significant change in step or trend. And you can see that really in the dots here being the original data and this bold line being the trend. There's not really a trend there, but as you can see, the number of dispensers is very low. We're talking between 40 and 70 dispensers per month. So it's not a huge amount. If we look at high dose codeine, we can see a significant 32% step increase at the time of upscheduling of low dose codeine, which we thought was quite interesting. It's not the medicine that's being affected, but it is the one that goes up. So there was a step up there, but no change in the trend. So you can see that line is already decreasing, and then it appears to jump up temporarily, but continue decreasing anyway. But a 32% increase there. Opioids and other pain medicines were quite interesting. At the time of upscheduling, there's no step change, there's no sudden change, but there appears to be a gradual change of about 1.4 in the case of opioids to 2% in other pain medicines. And you can see that here in the graph as that trend kind of pushes off. So that's the number of dispensers. If we look at the rate per 1,000 medicine dispensers, some changes occur. So again, we see no change in the low dose codeine following upscheduling. We see the same change in high dose codeine, a step increase, but it's reduced quite a bit once you combine it with the other pain medicines and calculate the rate versus the number. It reduces to a 25% step increase. And there's also a significant trend decrease as well as it returns to what would be its pre-schedule trend. You can see that also those trends we observed before in opioids and other pain medicines are no longer present. So yeah, rather interesting effects there, but it appears to be that the main change that you see when you upschedule low-dose codeine, you make low-dose codeine, I suppose, more challenging to access because you have to get a prescription, is that high-dose codeine actually temporarily goes up in number and rate of dispensers. And what about dose? You'll see here the other pain medicines graph has gone. That's because those are not morphine products. They're not opioids, so we can't calculate the dose for those. What we see here is, strangely, a brief step decrease in the dose of low-dose codeine. So the mean monthly dose briefly dropped and then appears to have come back to normal, come back to its pre-schedule trend. No change in high-dose codeine, so the mean monthly dose of what was being dispensed to workers did not change. And interestingly, a 13% step decrease in other opioids. So at the time of upscheduling of low-dose codeine, the mean monthly dose of other opioids has just dropped by 13%, with no other trend change there. So some interesting results, and there's a lot that we've gone through here. So if we summarize some of that data and look at the bigger picture here. So what we've got here is all our medicines again, and then the 4 outcomes that we've looked at today. So the percentage of workers ever dispense those medicines, the monthly number of dispensers, the monthly rate of dispensers, and the monthly dose of dispensers. So what's the summary here? Well, there was no significant change in the percentage of workers, the monthly number of dispensers, or the monthly rate of dispensers of low-dose codeine-containing products after upscheduling. However, low-dose codeine was very uncommon before and after upscheduling anyway, at less than 3% of pain medicines dispensed. And we'll get into that in a moment, of reasons why that might be. There was a significant step increase with a trend decrease in the monthly number and rate of high-dose codeine. So that's in the yellow here. You can see it was less common in workers after upscheduling, but at the time of upscheduling, it briefly spiked up and then went back down. And opioids that are not codeine, so the stronger opioids and pain medicines, both more common after upscheduling, with a significant decrease in the dose of opioids that were dispensed. So some kind of strange things happening, but this is why it's important to look at all the medicines and not just upscheduling. Because if we were just to look at, that low-dose codeine, if we were just to look at low-dose codeine, we would see that effectively nothing happens. But in fact, there was all this other stuff going on with all these other pain medicines. So why did this happen? Well, low-dose codeine was available at a relatively low cost. It's on the pharmaceutical benefits scheme. So people may have already had some lying around. They may have not purchased it from, purchased themselves out of pocket. It may have been relatively inexpensive. But one thing to note is that these are medicines funded by workers' compensation. And so over-the-counter medicines that people may have purchased, if somebody went and purchased that from the pharmacist, they would have to go and claim that. And they may not want to claim that, or more importantly, over-the-counter medicines are not necessarily recorded in great detail. They're not recorded in the same level of detail as a prescription medicine. With a prescription medicine, once the person lodges their prescription, the pharmacist can lodge the claim form with WorkSafe Victoria, which includes a great deal of detail about quantity of medicines dispensed, type of medicine dispensed, etc. So we're probably missing over-the-counter medicines, which probably explains part of why there's so few low-dose codeine products, because they were the only over-the-counter medicines in our sample. The rest were prescription. Also important to remember that these are claims for musculoskeletal conditions, so they're relatively severe claims with more than 10 days time loss. So for the general population, this may not be the case. But what our theory of what's happening is that workers who are being dispensed low-dose codeine, upscheduling occurs, they now need to get a prescription for that low dose codeine. They go to the GP, they may have simply just moved to a high dose of codeine. Now, if you remember, we've only got a 1-year follow-up with the workers in here. So that decreasing trend that we saw before is probably those workers washing out of our sample. Now, workers commencing after upscheduling would have always had to go to get a prescription for pain medicines. They wouldn't have got them over the counter unless they're getting plain paracetamol. But if they wanted opioids, they've got to go get a prescription. So they may have just gone to other opioids or other pain medicines. So for example, we saw the increase there of tebentadol as it became more common because it's better tolerated. So people may have gone straight for that product. Or in the case of low back pain, gabapentinoids like pregabalin, which is one of our other pain medicines, have become more popular over time. So what we see is that we think is what happened is people have moved to a more diverse array of pain medicines and diverse array of opioids and away from codeine products. So what does this mean? Well, the moral of the story is there's a consistent proportion of workers with musculoskeletal conditions who are prescribed pain medicines. And that's probably similar to the general population, realistically. But we see that here in our data. What we think is, as I mentioned before, is workers may have shifted to a more diverse array of opioids and other pain medicines. Like I mentioned, pregabalin has become progressively more common, particularly for low back pain. So yeah, there's more options out there, I suppose. But there's a lot of future research that we could do here. First of all, prescription drug monitoring programs like SafeScript have come in, and some research groups are doing research about the impact of that at the Monash Addiction Research Centre, notably. We also only included medicines that people have had funded by workers' compensation. So we could think about linkage to PBS or other options in the future to get a more comprehensive picture of these medicines. And most importantly, we could think about a longer follow-up. So we only included a year here because these changes are quite recent, and we want to make sure that we've got data that has matured, so people have had time to claim all these medicines. So we've only got a year follow-up, but in the Victorian Workers' Compensation Scheme, even if somebody's on weekly benefit payments for 130 weeks, they're eligible for healthcare for up to 52 weeks after weekly benefits end. So that's theoretically a 3.5-year follow-up period. And myself and other colleagues are actually doing work with that at the moment to do a trajectory analysis across a full 3.5-year sample to see people's long-term opioid use. But thank you, everyone, for listening to that. Please let me know if you have any questions. Janine, would you like me to stop sharing my slides? Or?
Yeah, I think so. Thank you.
Sure.
Yeah, thanks so much, Michael, for sharing your knowledge. It's a really interesting topic and a very important one at that. So we'll move to a Q&A session now. And yeah, so if you've got a question for Michael, please put it in the Q&A along the bottom of your Zoom, and we'll endeavour to get through as many as we can. So I might just start with, I'm just sort of interested in, like, these results were from WorkSafe Victoria, yeah? I'm just interested in the other states of Australia and, you know, how that relates to it, because there wasn't sort of a big drop in low-dose codeine. Could you just expand a bit more on that?
Yeah, so we used Victoria's data because while healthcare is recorded in detail in most Australian jurisdictions, what we've discovered over time is that Victoria and South Australia are really two workers' comp authorities that are recording medicines in great detail, or detail that enables us to do this kind of analysis. I would have to just hypothesize as to what happens in other states. I imagine it would probably be quite similar to what we've seen here. There are other things that we could consider. Victoria has a medical excess amount, which has varied over the years. At the moment, it's about $700. So perhaps we could be missing some opioids, which may have been those low-dose codeine. You know, if people start their opioids on a lower dose, perhaps those were caught in that medical excess amount that we can't detect. But I imagine it'll probably be similar between states and territories. There is some other research, as I mentioned, researchers have just used the entire PBS to look at this, and you can see that low-dose codeine drops away on the PBS because that captures everything, and that's nationwide. But I can't imagine there will be a huge difference with the other jurisdictions regarding this.
Excellent. Interesting. Yeah, it's interesting that low-dose codeine didn't really go down, and you sort of talked about that a little bit. Is there anything you want to expand on that? Just it was quite interesting, I thought.
Yeah, look, I think it's more a case of, as I mentioned, detection in the data, and like the steps required to acquire that medicine. So, it was pre-2010, you actually could get that kind of medicine from anywhere. Then it became 2010, it was changed to pharmacy only. And given its relatively low cost, people may not have been claiming it, or as I said, there are large portions of the data that are just over-the-counter medicine. We do our best, and as does WorkSafe, to clean that data up, but sometimes it just can't be detected. So I think there's probably more people that were being dispensed low-dose codeine. That drop in the mean monthly dose of low-dose codeine may have been people suddenly starting to claim that medicine, but yeah, I just think it's people, if they're getting a prescription anyway, they're probably getting a larger dose or higher dose of codeine or other opioids.
Yeah, sure. We've got quite a few questions coming through on the Q&A. We've got a question: do other opioid options cost more than, say, codeine?
Depends on a number of things. Depends on the PBS price, which tends to vary over time, and the benefit at which people can be paid back from the PBS, or even in some cases, if it's not listed on the PBS, WorkSafe would pay for it. Other opioid options may have costed more than low-dose codeine. I would have to check exactly what those prices were over time. It would depend on the pharmacist as well, and partly the brand as well, what price they want to advertise there.
Yeah, sure. Excellent. We've got a question here. Hi from Toronto, Canada. Great
Yes.
presentation. Apologies if I missed this, but I wonder if you were looking at dispensers within a specific amount of time after onset of the injury claim. For example, the first year. Did you account for duration of disability in your analysis?
A two-parter there. First, yes, we looked at this. We included medicines that were dispensed to workers 31 days prior to their insurer, the date the insurer received their claim, to 365 days afterwards, so the first year. We use the date the insurer received the claim because we think it's a little more precise than the injury date. So if somebody makes a claim for low back pain, that's kind of the date the low back pain onset was reported. So we prefer to use hard dates like the date the insurer received their claim. But that tends to be the date the insurer received the claim tends to be quite close to the date of injury or date of condition onset. But we go back 31 days, so a month prior, just to account for that. So effectively 13 months of possible dispensers per worker. And in terms of duration of disability, we didn't adjust for that in this case because we were looking really at the first year of claim. We could have, perhaps an option for future research. We have done that in the past, but sometimes we haven't as well.
Excellent. We've got another question here. Do you think there's a link between the cost of living and the increased claimed volumes of prescriptions?
Potentially. Medicines tend to be. That's a good question. I think more for a health economist, but to note, I suppose the price of medicines, the PBS will pay for a medicine stays pretty static. Over time, maybe. I would have to take that one on notice, but potentially somebody for the Centre of Health Economics in our school.
Certainly. Another question, how do you envisage this information could be insightful for health practitioners when managing patients with muscular conditions in workers' compensation claims? Will this be an extension of your research in the future?
Yeah, a great question. I mean, this is more, our research, or this research in particular, is probably more beneficial for policymakers. Just as an example of a federal policy or a Commonwealth policy in terms of medicine regulation having a fairly large impact, as we saw on workers' compensation, which tend to be state schemes. So this is more policy. I suppose for clinicians, maybe in the future, it would be good to look at the disability duration associated with people using various types of opioids. We have done that in the past with low back pain, and we found that people that tended to use more opioids tended to have longer off work. However, the issue with that is that it's what came first, the opioids or the pain. And since we don't, in this kind of administrative data, have a pain severity, we can't say which came first. Were they already in pain, so they were having opioids, or did the opioids cause their longer time off work? In the future, it'd be great to work with clinicians to capture that kind of data, that kind of pain severity data. But I think this stuff is more, this particular research piece is aimed more at policymakers.
Excellent. This next one's more a comment rather than a question. But we have some great data within WorkSafe and TAC in Victoria that when people are attending a pain management program reduce or cease their opioids, they have reduction in pain intensity and better mental health outcomes. So that's interesting.
That's an interesting one. We should look into that. I think if that person from WorkSafe wants to get in touch, that sounds very interesting.
Yeah, definitely. Very interesting indeed. Excellent. Another question, autocorrelation can impact the level of slope estimates in ITS analyses. Did you investigate this at all?
Yes. So good technical question there. We did adjust for seasonality. So we used sine and cosine terms to adjust for seasonality in those analyses and autocorrelation. The monthly number were negative binomial models, and then we use generalized least square models for the continuous outcomes, so the rate and the dose. But we did adjust for autocorrelation and seasonality in those analyses.
Excellent. Next question. Have you considered the effects of limited availability of low-dose codeine following the upscheduling?
That's a good point. Limited availability. No, I suppose we probably wouldn't have been able to do that with this analysis. We could look at the supply via the PBS, perhaps as a covariate in a future analysis. But I would have to check if the supply changed drastically or changed in certain regions, which it might have. But that kind of PBS data is publicly available, so we could look at that in the future.
Excellent. Okay. The next one is, I may have missed this, but did you have any hypothesis for what may be driving the decreasing mean dose for opioids other than codeine post-schedule changes?
So our theory there is that, there's a couple of options. Well, one that, there's better awareness of opioids and their relative effectiveness, particularly in clinicians. Prescription drug monitoring programs have also been introduced. So there could be a number of things affecting it. The fact that we saw it right after and in this data seems to indicate to us that people are probably, if they've got to get a prescription anyway, rather than go for high-dose codeine, the GP might say, well, look, there's this product available. It's a lower dose opioid, like tapentadol, for example, and it's more tolerable. So people may be just going for that kind of option. There's less side effects, for example. That would be our theory. But there's a lot of other things going on as well. That's why we tried to restrict our time series for the interrupted time series analysis, because there's so much happening with the introduction of certain things. So one thing to look at in the future would be the introduction of SafeScript in Victoria, which a lot of colleagues at the Monash Addiction Research Centre have started to do, but using a general population data set. It's not workers' comp specific.
Excellent. There's so many questions going through this. Lots of interest in this. If there's different pain relief cost pathways, did this initiative end up costing more in total? If so, did it cost scheme or injured workers more?
Good question. Cost question. I think we need to get a health economist on the next analysis. I do with this one. Would it have made a huge difference to the cost? I can't imagine that it would have made a massive difference, but we'd have to get a full analysis with a health economist to do that one. Sorry, that's a little bit out of my. I don't want to give you an answer that's too far out of my wheelhouse.
No problem at all. I think we've got time for one more question. Is there an opportunity for you to investigate the link between opioid use and medication-induced injuries at some point in the future? We're seeing growth in this area in the South Australian scheme and want to support workers and providers towards minimising these injuries where possible. Yeah,
I mean, absolutely. It would be a matter of getting the right data. So with this data that we had in this study, for example, these folks have musculoskeletal conditions, and the information that we have about them is their condition they're claiming for. So if there is a way to detect people having medication-induced injuries, that would be great. And I would imagine that would probably be doable through a linkage between, for example, emergency department records and workers' compensation records. So in another study we've done in New South Wales, we have linked the New South Wales a sample of New South Wales workers' compensation claims with PBS, MBS, admitted patient data, and emergency department data. And then we can look at emergency department admissions, full admissions to hospital, everything. So that kind of linkage is possible. So that would be really interesting to see if people have had medication-induced injuries, which we know that they do have. Like one of the studies I mentioned at the beginning of the presentation was to look at whether there were changes in emergency department admissions for poisonings following upscheduling. I believe that was done in New South Wales, but if there's a way to circulate these papers, I can find the exact reference, but that would be very interesting.
Excellent. Okay. Thank you so much, Michael. So a copy of this presentation will be available to view on ISCRR's website in the coming week. An evaluation pop-up box will appear shortly, and please share your feedback. And also, if you're interested in attending future sessions, we can add you to our mailing list. We'll continue to run webinars like this on a range of different topics throughout the year. And so if you've got a topic of interest that you'd like us to cover, please contact us at info@isccr.com.au. Thanks so much, everyone, for joining us.